Brilliant. So welcome everybody to our very first partnership clinic, this one focusing on the very important topic of mental health around all of the partnerships that you're engaged in. I think I know most of you, but my name is Nadine Ferris-France and I'm the Executive Director for the Irish Global Health Network, the host home of ESTHER Ireland. So you're all very welcome, and we thought that it would be nice just to start by finding out who's in the room, just so everybody knows each other. We might just go around with a quick set of introductions, so that yeah, we know who's in the room and how we need to network and who we need to connect with. So why don't we start? I'll just tell you, I'll go on my screen who I can see. David.
Hi, David Weeklim. I'm the Director of the Global Health Programme in the HSE. Nice to meet you all.
And Anne.
Hi, maybe I'm the only Anne, I'm not sure.
Yes.
Hi, I'm recently retired GP with an interest in mental health. I actually still work in mental health as a therapist. I'm a registered therapist as well. I'm not at the moment involved in a project in mental health, but I hope to be soon involved in a particular project in mental health in Malawi.
Super. Well, Anne, you're very welcome, and you've definitely come to the right place to be involved and connected with others who are interested in partnerships in mental health and Malawi. So welcome, Anne. Really lovely to have you with us.
Thank you.
Kieran. Don't know if you can hear us, Kieran. You're muted if you can. Not. Okay, oh, there you are.
Hey, can you hear me?
Yes, perfect. Hi, Kieran.
Sorry, I'm Kieran Kincannon. I'm newly appointed consultant psychiatrist in homelessness and social inclusion in Cork Kerry, and my remit is homelessness, asylum seekers, and the traveller population.
Well, fantastic, Kieran. You're really welcome. Thanks for joining us today.
Thanks.
Maria.
Hi everyone, my name is Maria Kidney. I'm with Brighter Communities Worldwide. I'm sorry, my connection is quite poor. I'm in Kenya at the moment. We facilitate and work with the partnership between Londiani Sub-County Hospital and
I'm going to finish that for her and say Mayo General Hospital.
I'm really here to learn, to listen and learn.
Mm-hmm. Thank you, Maria. Delighted that you're here, and we look forward to learning from you as well. So thanks for that. John, how about you?
So I'm a consultant psychiatrist and recently retired from the Mater, where I was for about 26 or 27 years, and I'm still based in the Rotunda. And I'm involved in the Royal College, not the Royal College, but in the Irish College of Psychiatrists. And a special interest group in global mental health was formed just about 2 years ago. So I'm the vice chair of the special interest group. And one of the projects we want to become involved with is that we gratefully received a grant from ESTHER Ireland. So we're looking at establishing a partnership between the College of Psychiatrists of Ireland and the Zambian Mental Health Services. So we're going out on the 22nd of July, and we're having about 2.5 days meetings with the relevant stakeholders in Lusaka. And our goal is, in a sense, to try and establish like an e-learning program to help build a sustainable mental health service in Zambia, and also to address the very significant deficit in capacity that's there. So a country of 18 million people with 3 psychiatrists working in the public sector. So my interest essentially is that also, as David knows, but I worked as a medical officer in Zambia in the early 1980s. So I've long connections with the country, with people still there. So it's the mental health aspect and the e-learning that's what I want to get involved with.
Fantastic, John. Brilliant. Great to know, and you're very welcome. Cara.
Hi, my name is Cara Munn and I'm the ESTHER Programme Coordinator. So really great to see partnerships represented here today. Thank you.
Thanks, Cara. Thora.
Hi, it's Thora Burgess. I'm the General Manager working with David in the Global Health Programme in the HSE. So nice to meet everybody.
And Zikar.
Hi, good afternoon, everyone. My name is Zika. I am an MPH student at the University of Limerick. So I recently just concluded my practicum with the HSE Global Health Program. I worked with Thora and Dr. David, and there's another lady, I don't recall her name. It was, Teresa, yeah. So, and that's why I'm here. We conducted a situation analysis on mental health and mental health services, and you'd hear more about that shortly.
Thank you, Zika. We're looking forward to that. Catherine.
Hi, everyone. Hope you can hear me. My name is Catherine. I recently just did my with HSE for health and mental health. That's why we're here to present to you some of our findings. And we worked with Dr. Wiklam, as Zika said, and everyone else, Thora and Teresa. And we're glad to present to you today.
Super. Thanks, Catherine. Very good. Maisie.
Hi, everyone. I'm the Programme and Communications Officer with the Irish Global Health Network and ESTHER Ireland. So nice to meet everyone.
Great. Great, what a group, and it makes me also just want to share with you that on a different hat, I also work on mental health in Zimbabwe with young people living with HIV, on self-stigma and shame, and have been for the last probably 7-8 years. So I really look forward to this discussion. David, I wonder if I could hand over to you and you can just kind of set the tone for us in terms of what is this partnership clinic, what are we here for? What's it about? And also just to let everybody know that we have, we've kind of signed ourselves up here to be here until 5 o'clock. And of course, if we finish early, that's absolutely great, but we have this space available to us. And David, you could perhaps give us a little bit more information about today and also about the HSC program. Thanks.
Yeah, great. Thanks, Nadine. And thanks everyone for joining. It's great to have such a group coming together. This is our very first partnership clinic, so this is new for us, and we're looking forward to the engagement discussions this afternoon. And this is really coming about in response to requests from people for events like this, where smaller groups might come together to learn and share with each other. And I mean, you all know that the ESTHER program is really about partnerships, and what we're all interested in is high quality partnerships between our services and institutions of different types in Ireland and counterparts in low and middle income countries. And many of you are involved in those already, some of you are developing them. And we're very committed to that partnership approach where we work together in a spirit of partnership with other institutions. And also we don't go it alone. We work together as teams of people in institutions trying to support institutions and services. So as you know, lots of the other activities that are done under the ESTHER program, which is, as Nadine said, is kind of home. The home is in the Irish Global Health Network. The HSE works with the Irish Global Health Network kind of through a funding agreement. And so it's a very important part of the HSE strategy, while the operations of it and the implementation sits under the Irish Global Health Network. And you're aware of things like the small grants program that is available for new and established partnerships. We run various events during the year, like the Partnership Forum. We have a regular newsletter, the Partnership Panorama, and there's lots of ways in which we try and bring people together, because I think what we find is that if we want to run good partnerships, we learn how to do it from interacting with each other. And I think the idea then of the Partnership Forum is bringing together a smaller group, is that we would bring together people with something in common. So that's the idea of a themed approach. And we're starting with the theme of mental health. And I'm glad we're starting with that one. I think we work with many different health issues. And there's no doubt that one of the most important of the health issues that we'll encounter in our work with other countries is mental health and mental illness. And it's a very neglected area, and an area where I think countries across the board are all needing to develop and improve services and responses for mental health and mental illness. So we look forward to discussion on that theme this afternoon. And we really just invite you to contribute and to ask questions, to share. And this is a learning for all of us. And I think every time we meet like this, we all learn from each other. I'm always learning. I'm sure things you say will teach me, and hopefully that the things that will get shared will be of help to you. And any ways in which the ESTHER program can support you if you're involved in partnerships, well, that's what we're about. So we like to hear from you about that. So what we're going to do is kick off with a short presentation from Catherine and Zikar, and they will already introduce themselves. And we were so pleased to have the opportunity for them to join us this year. And this is the third year that the Global Health Programme in the HSE have had MSc Public Health students doing their practicum with us. And when it came to what their project would be, we were very, very keen to deepen our understanding of mental health issues and mental health services in the countries we're working in. And there's 5 countries primarily that we focus on in the HSE Global Health Programme, and they're Ethiopia, Sudan, Tanzania, Mozambique, and Zambia. And so what we asked them to do was to do a situation analysis for us to help us learn more about mental health in these countries and mental health services, and that would inform us in the work that we do in ways in which we can be supportive. And I think this will be relevant and hopefully useful for all of you. And we will at some point be able to share the report. It's part of their practicum, so we might have to wait a bit. I'm not sure, we can check. But for now anyway, we're delighted they're here today to present briefly. It will only be brief today, the work that they've been doing, and then we'll follow on with discussion after that. So we'll hand over to you, Zikar and Catherine.
Thank you, David. So Catherine will begin and I'll take it up at some point. So Catherine, just let me know when you want me to move the slides. Over.
Okay, it's okay. I can see everything. So as I had said earlier, can everyone hear me, please?
Yeah, yes.
All right. As I had said earlier, my name is Catherine, and this is our practicum findings. Our topic was the situational analysis of mental health and mental health services in 5 countries. That was Ethiopia, Sudan, Tanzania, Mozambique, and Zambia. Yeah. So I'm going to be talking about the objectives, the introduction to our topic, the objectives, why we intend to carry, what was our aim, and this, the methodology. Then Zika will take over from there. So the introduction about the 5 countries that we are talking about, they are all countries found in Africa, and these countries have a concern in the mental health area. There's a growing burden of mental health within the 5 countries, but it's an undermined issue since the health system or the government or the people in charge are not prioritizing the issue which we are trying to research about, because they think there are other health priorities. So there are limited resources that are put in place for mental health services and mental health as a problem, meaning mental health is pending to be sorted out in Africa in the 5 countries that we are looking at. Yeah, the next slide. Then the objectives, why we're looking at the situational analysis of mental health and mental health services. We intended to describe the health-seeking behaviors towards mental health in the HSC partner countries, as talked about, to describe the type of formal and informal mental health care available to the people affected by the illness, to analyze the national mental health policies and strategies in HSC partner countries, to develop recommendations on creating sustainable mental health and
health services in the HSC partner countries, and to identify key areas in the partner countries which could be potentially supported by Ireland. Those were the objectives. And then our methodology for carrying out the situation analysis, we scanned both open and closed peer-reviewed literature from primary research, secondary and systematic reviews between the years of 2000 to 2021, because we believe that the years before 2000, maybe the papers or the information wasn't like a little bit up to date. So we tried to bring it closer to the 2000s. We have a better view of what's going on in these countries. Then we searched Google for mental health reports on the 5 countries. And then we identified relevant data sources from government institutions, because we had to find out what's happening in the health systems. Such information usually cannot be found in articles, so you have to go deep into the data sources of government institutions, non-governmental institutions within those countries to get that information. And then we use the PESO analysis, which is the political, economic, social, technology, the legal, and analysis developed from the literature. That's how we use, that's the analysis we use to identify our literature that we found out from the countries in the topic. Yeah.
Thank you. Yeah, thank you so much, Catherine. I think you did a good job at introducing. So because we're constrained for time, in the report, which is definitely more robust, we were able to, categorize each country and discuss each country with as much information that we had. But for this presentation, would be collapsing all 5 countries and just discussing our general findings. So if we can see the graph on the right here, we can see that when it came to, in terms of the prevalence of mental health disorders, Ethiopia ranks highest among the 5 countries, and Zambia ranks lowest with 4.0 among the 5 countries. It would come up later in our limitations, but it's important to know that finding the overall prevalence or the burden of mental health issues within these countries was a challenge, because there's really low research output on mental health and the situation of mental health, largely in Africa and also in these countries that we studied. So moving on to the health-seeking behavior, generally overall, among the countries, we could see that the barriers to seeking help for mental health include poverty. It included low education and mental health literacy. In all of the countries, mental health was seen as, a spiritual problem. It was seen as, there was very little demand for mental health issues when it came to, especially at the facilities. And also cultural beliefs were also barriers. Like I mentioned earlier, they believed that, it wasn't scientific, or it was caused by some other factors that we'll explore later. Stigma was also an important barrier to seeking care for mental health services. Also, the location of the service was a barrier, which we'll get down into that shortly, because most of these services were located in the city's capital. So there was geographic barrier. People in the rural communities could hardly access, the tertiary institutions, that are in the capital. And also administratively, most of the healthcare systems in those countries, the way they were structured, made it a bit harder for people in rural communities to access those services. And also across the 5 countries, we saw that there was a preference for traditional and religious healers as opposed to orthodox medicine. Then facilitators for seeking health for mental health disorders, they were quite few and far between based on all the documents that we were able to access. But some of them suggested that support from development partners, as in the case of Ethiopia, I think that was in 2020, the HSC actually supported some health workers, during the COVID-19 response, just to ensure that they were being taken care of, that their mental health were being taken care of as they were responding to the pandemic on the front line. So that was one example of a facilitator, because it got the health workers talking about mental health disorders and how it affected them as frontline workers. Also, some studies suggested that family support, people who have access to family support, usually have better mental health outcomes and are usually more encouraged to seek help in terms of mental disorders. Also, expanding the skill mix in mental health. Studies suggested that expanding skill mix in mental health also helps people seek better care, because most of these, the mental health institutions and care available are only available at the tertiary level. So studies suggested that if we sort of task shift, maybe train lower cadres of healthcare workers to be able to provide basic mental health services, it would encourage people, especially underserved people, to seek care for mental health services. Now, the contextual factors, more into detail. Across the 5 countries, we could see like a trend when it came to contextual factors affecting mental health and mental health disorders. So cultural beliefs was one of them. Most people in those countries believe that mental disorders were caused by supernatural forces. Another contextual factor was religion. A number of people from the studies that we saw across the 5 countries believe that mental disorders were a consequence of spiritual disobedience or lack of, and they relied heavily on religious leaders to care for them when they had mental health disorders. Also, gender. In most of the studies that we saw, especially in Sudan and Ethiopia, men were more likely to suffer from mental health disorders resulting from substance abuse. And I would like to say again that some of these data, there's clearly underreporting. So, but based on the information that we had and the studies that we saw, these are like the contextual factors. Also, conflict. Sudan has been in civil conflict for some time, and this civil conflict has caused instability and hindered the provision of overall health services. Studies also suggested that there's been increased cases of depression and PTSD among women and children, and also among displaced persons, especially in Sudan. So conflict was a major contextual factor in Sudan. Then the health system factors, as I was sort of hinting earlier, for across the 5 countries, 4 of those countries operate a 3-tier health system. So Ethiopia, Sudan, Tanzania, and Mozambique, they operate a 3-tier health system, which is basically the national level, the regional level, and then the ward level. But Zambia operates a 2-tier health system. And the reason this is important, because the way their health system is structured also affects the way that mental health services are rendered. So in most of these countries, mental health services are mostly found at the tertiary level, which is at the national level. And most times facilities that offer mental health services can only be found at the tertiary level, creating an access barrier for people who live in rural communities or who live far away from the country's capital or from the big cities. Health system and the political administration in those countries are also similar. So as they have like maybe the national government, the regional government, and ward level or local government, that's also how the health system in those countries are structured. Also, oversight and policy making exists at the national or regional level in all 5 of the countries. When it came to financing, generally in health, all the countries fell short of the Abuja Declaration, in which African leaders agreed to allocate at least 15% of the government budget to health. None of those countries were allocating 15% of their budget to health. There was overall high out-of-pocket payments for health. There was also limited insurance for health, and where the insurance was existed, mental health was hardly covered. The government allocation and expenditure for mental health was mostly unknown across the 5 countries, and in the countries where we could find data on how much the government actually spent on mental health, the expenditure was abysmal. When it came to human resource and service delivery, most psychiatric institutions existed at the national and regional levels, like I mentioned earlier. Most mental health services were institutionalized, so there was limited community basis. And this also created more problems, because when someone reported, with mental health disorders, which most times was quite severe, that person is usually, put in an institution, and this causes like some sort of stigma. People do not want their family members to be known as being in a psychiatric hospital. So there's very limited community-based programs to deal with mental health disorders. And where they actually do exist, the practices are not very orthodox. There were also issues of poor infrastructure in psychiatric hospitals and low bed occupancy. There was less than 5% of mental health personnel per 100,000 of the population. So human resource for mental health was quite abysmal in those countries as well. There was also high attrition of mental health personnel and limited motivation for mental health personnel within those countries. When it came to policy and legislation, all the countries except Tanzania have mental health policies and strategic development plans. We're not able to see all of those strategic development plans, but we know that we saw documents that suggested that they did exist. Ethiopia and Mozambique did not have mental health laws. So the other countries, Zambia, Sudan, Mozambique, I think, the other countries had mental health laws, but Ethiopia and Mozambique, they do not have any legislation on mental health. And also, there is a gap between the existence of these laws and these policies and the actual implementation. And some of these laws, I think that was for Sudan and Zambia, some of these laws would also need revision because some of the way mental health disorders are referred to and the way the law stipulates that they should be handled are quite antiquated, for lack of a better term. Then moving on to the country comparison, because there was paucity of data when it came to finding, standardized data to compare across the three countries, we had to use the WHO Mental Health Atlas of 2020 to try and, cross-tabulate and just compare the situation of mental health across the 5 countries. The only country that we did not see an updated mental health, where's this laser pointer? An updated mental health statistics was Mozambique. The latest that we saw from WHO was 2017. But from this table, what are the most important things to see? We can see if we come under workforce, we can see that Ethiopia has the lowest mental health workforce per 100,000 of the population. It's actually less than 1. Next to that is we have countries like Tanzania and Mozambique, but overall we can see that none of the countries even have 5% of mental health personnel per 100,000 of the population. On this side, we can see the disability adjusted life years caused by mental health. We can also see that it's quite obvious that research outputs on mental health in these countries are quite scarce. You can see not known, not known, not known. When it came to mental health law, like I mentioned earlier, Tanzania, Sudan, and Zambia, they do have mental health laws. Ethiopia and Mozambique do not have. Most of them have policies, except for Tanzania. When it came to functioning mental health promotion and prevention programs, Mozambique, Tanzania, and Sudan did have some evidence of mental health promotion and prevention programs.
And Zika, just 2 minutes left.
Okay,
Thank you.
It up now. So this is in the reports, you'd be able to see like a more detailed information on the PESEL analysis. These are just screenshots on it, and I may not have the time to go like in depth into it. But moving on to our key findings, and I think this is where the major information is. In all the 5 countries, religious and traditional rulers play a critical role in the provision of mental health services. They also play critical roles in shaping the health beliefs and value systems. In all the 5 countries, there was limited awareness on mental health disorders among members of the community. And this was a major driver of stigma and poor health-seeking behavior. In Sudan, there was stigma. A study suggested that there was stigma surrounding the word psychiatric. If you recall earlier, I mentioned that most of the mental health services in those countries were institution-based, and this made demand for them very low because of the stigma surrounding, psychiatric hospitals. And in Mozambique, Tanzania, and Ethiopia, there's an increasing number of mental health cases related to drug use. On the supply side, all 5 countries fall short of the WHO recommended mental health workforce. Most of the countries recognize the need to integrate mental health services into primary healthcare. However, there's a gap between their policies and the actual practice. Most mental health facilities exist in the national and tertiary level of care. And for most countries, the government's allocation and expenditure for mental health are unknown. Overall, there was low research output for mental health in the 5 countries. Our recommendations, we structured our recommendations into 3. We have into 2 broad categories, which are short-term and long-term interventions. So on the short-term interventions, we suggest that based on our findings, that the HSC Global Health Program can work with in-country civil society organizations to implement anti-stigma campaigns, which will create awareness and stimulate free conversations on mental health. The second hand, you can improve service delivery by supporting trainings, by supporting the development and implementation of quality assurance and standard of care protocol, because there was very little protocol on how mental health services were delivered, and also support the ongoing use of traditional healers in Sudan. So if there was more time, I would have gone into more detail on that, but just to improve the delivery of health services in those countries, they had to task shift and co-opt lesser cadre healthcare workers to be able to provide mental health services. And the last one, which is more of long-term, is to strengthen the mental health systems in those countries by supporting the development of laws, advocating for increased political will, advocating for increased budgetary allocation, providing technical support, and supporting skill exchange between, more developed countries like Ireland and those countries. Lastly, I'll just run through the limitations. Like I mentioned earlier, we had, quite a short time frame to dive into this. Also, there was poor research output, but we had to make do with the papers that we found. And our findings also suggest that mental health issues are often underreported due to stigma. So we may have all this data and all this information, but because of underreporting, the scope of the problem could actually be bigger than we can currently see. So in conclusion, ensuring equitable and affordable access to mental health services in LMICs is essential for achieving the Sustainable Development Goals. Ireland's A Better World policy reinforces Ireland's commitment to supporting the achievement of SDGs in LMICs, and our recommendations align with this policy. And if they are adopted, Ireland would be able to support SDG 3 health and well-being in these developing countries. Thank you.
Thank you, Zikar. Sweet photo to end on. Thank you so much. Thank you, Zikar. Thank you, Catherine. Fantastic presentation, and well done for your work. That is such an important contribution that you have made now to shaping the thinking and the understanding around the priorities in mental health. So thank you hugely for that. Great. So I guess we just wanted to just to open the floor really to have a conversation. David, I guess I'm checking in with you. Is there anything you would like us to kind of focus on in relation to that report specifically before we broaden the discussion that would really just cover, partnerships in every shape or form? I'd like to just to try and help us kind of map this conversation.
Yeah, I think we may be useful to be thinking of the whole kind of spectrum. What we're looking at. We're looking at both mental health and mental illness. And I think what came out strongly from the report was that the need for kind of broad-based approach that are going to reach the whole community. And a lot of that is promoting positive mental health, as well as then addressing mental illness at the community level. So I think that probably be just maybe to say that. I think you can see that there's a wide spectrum of needs that countries have. So there's a wide spectrum of entry points for working with countries and with services to help bring about improvements. So I think there's scope for many different types of partnerships. So maybe that's kind of useful to say. And I'm sure people in this meeting even here will be thinking of different ways of engaging within the whole system to improve mental health. And there's a need for engagement at all levels. You need the engagement at community level. You need the engagement at the higher level. You need the maybe more generalists to provide care. You need the specialists for referral and to engage with governments to change the things like the laws that need to be addressed. So there's lots of needs and plenty of scope for different types of engagements. So So I think it's maybe just to say whatever way you might be involved, that there's not one way, there's not one size fits all. There's all sorts of ways in which we can engage from an Irish perspective through different types of partnerships.
Thanks, David. Yeah, so I guess the floor is open. I mean, that was really useful in terms of just setting some context for us. Any thoughts, any comments on that? And I know there are some specific questions that we've already had in relation to, you know, specific things around partnership, but let me just open the floor and see where we go, and then I'll bring it around. Anybody like to come in? And please, can everybody just feel very relaxed in this space? It's a conversation, it's a learning opportunity, it's just an opportunity to share. You know, the very nature of a partnership clinic is just to be here without knowing exactly what's going to come up, and see if as a group we can tap into the wisdom that's in this room, in each and every one of us, just to support each other as we develop these partnerships, and also as we really think about the context of partnerships and mental health and well-being. So the floor is open.
So Nadine, I might jump in,
Please.
okay, because I mean, I thought that was a super presentation, Catherine and Zikar, and I'd love to hear it again, in fact, because I'd love to actually go through it line by line and discuss. It was like there's so much in it. But maybe to sort of to start off, in the sense that if you take, Zikar, what you've gleaned so far, and Catherine, when you look at your conclusions, actually, where would you start? Where would you start yourselves?
Okay, thank you for that question. So for me, I'd say I'll start by starting the conversation, so to speak, because mental health in most of those countries is still something that drives a lot of stigma. So before you can even maybe support the systems or improve service delivery, you need to be sure that people are aware first. So if you ask me, I'll say, let's start with creating awareness. When people are aware, this will increase demand for those services. And then you can now work with the governments to improve the services, or at least make a case for the government to actually, you know, invest in improving mental health services within those countries. Because if you tell them people are aware, a lot of people are talking about mental health problems now, but your services, you need to be able to provide these services for them, and they can actually see that there's demand for these services. They'll be willing to invest more in it. So I'll say, let's start by creating awareness. There is limited awareness across board. I would start by creating awareness. Yeah.
And again, just a follow-on question, if you don't mind, and then I'll be quiet in a sense. But has there been much work done, in a sense, say, with like working with traditional healers, or working with religious leaders? I know, for example, in the field of obstetrics, that with traditional healers who were, in a sense, looking after women who delivered in the bush, essentially, that one of the very practical measures was that traditional healers were given a stick of a certain height. And the height was, they were instructed to say that, look, if a woman was shorter than the stick, she was likely to have problems during labor. And in fact, that worked in Zambia. When I saw that, that worked really well. You know, so it was working with the traditional healers who, you know, came from different, maybe theoretical backgrounds, whatever, but very practical thing like that. So in mental health, did you come across any studies of working with traditional healers or religious leaders?
Yes, definitely. In Ethiopia, in Sudan, I'm very sure that in Ethiopia and Sudan, there were studies where traditional and religious leaders were actually co-opted as people to provide some sort of rehabilitation at the community level for people suffering from mental health disorders. Even in Ethiopia, there are currently over 30,000 health extension workers who were trained by the government to provide not specifically mental health services now, but other health services, you know, because there's generally like a problem of services reaching underserved communities, especially in rural areas. So these health extension workers which some of them included actually traditional leaders, were trained to provide some of these services. So there's definitely evidence that, you know, in Ethiopia, in Sudan, and I think in Tanzania, there's some work done with traditional leaders, you know, and, you know, traditional healers to provide some sort of services to people in the community. I'm very sure of that for Ethiopia, and I think Sudan as well. So yes, there's evidence that, you know, traditional healers, even in the least, even if it's to just provide some sort of referral and tell them, look, this thing is not all spiritual. You can actually go to a facility to seek care for mental health disorders. Yes, there's evidence for that. And it's already being done in Ethiopia and in Sudan.
And some articles did talk about how some traditional healers actually recommend these people, like, this issue cannot be handled here. You can go further to the medical side of it instead of just being here. There are some articles which talked about it, like some traditional healers actually know that some issues cannot be handled by them, and a person has to seek further help than just the basic of maybe the anointings or the prayers, something like that. Yeah.
That's very interesting, Catherine, because I mean, certainly with the Zambian project that we're starting, like, one of the real concerns I have is that under no circumstances do I want to see a situation where, say, four of us psychiatrists are going out in July, and I don't want to see a situation whereby, in a sense, we're going out and saying, well, this is the way it's done and this is the system that works. In other words, I think that's completely inappropriate. You know, and that's why I'm very interested, just from your experiences and the research, in terms of different ways that have been tried. And to me, for example, with, you know, if you think of the mental health service we have in Ireland here, it runs in parallel with the like medical and surgical services, you know, but it's distinct, it's separate. And I think that there's, you know, tremendous potential, for example, in training people at maybe quite low levels in a sense, but training people in much more holistically, you know, and rather than trying to create a duplicate parallel system that we have here, and that's based upon your address and your catchment area. In other words, I think that's completely inappropriate for, say, a lower middle income country. So they're just some thoughts. So I'm very interested in what you're finding, and it'd be lovely to just, you know, to look at them in more detail.
Mm-hmm. Thank you, John. David.
Yeah, I think you've raised a good point there, John, about, you know, with your partnership, where you're inevitably focusing or going in as initially as a group of psychiatrists starting at the highest level, and then you say, well, what's that? How is that relevant to this very, very large population of people who need services at the community level? And we face something very similar in our work with Ethiopia, where we asked, following an initial project, we asked people, our contacts there, where maybe we could add value and do something, and they came back and said, could we help them develop their clinical psychology training? And then we were challenged by the Irish embassy there, saying, well, that's only going to serve a handful of people. That's not what the country needs. And we know that, but it's, and what I said is, well, but that's our entry point. That's what we've been asked. We were asked to do it. We come in, we'd start there, but we recognize that that's not the answer to the country's needs. They do need those people, but that's a tiny tip of the iceberg. So, and I think you might find that as you engage with people working in the area of mental health and mental health services, you might start to see opportunities, as you know, to be able to support more broadly. But you need to start by building up the relationship and the trust with your partners. You start working with them, and as you do that, then you hopefully be able to start looking at things like that. I think the work with traditional leaders can be very helpful, because they're a great resource at the community level. They're people with skills who can provide a lot of support, and if they can be with training to be able to refer then as appropriate then for more specialized services.
Mm-hmm. Thanks, David. Hilbery, your hand is up, and you're welcome just to introduce yourself as well, if your connection is good enough. Am I saying that correctly? Hilbery? Hiberet, perfect.
I didn't realize Hiberet was on, but she's much better placed than me to talk about what I just said about Ethiopia.
Excellent, Hibaret. We're definitely coming to you. Hibaret, your connection. Okay, she's sorting out her connection. Okay, good. We'll hold on for your connection. While I'm just waiting for Hibaret, a couple of things I wanted to just share about. I think that we talk about mental health, and I think that when we're working in these kind of partnerships, and in general working with partners in different countries, it's like an opportunity to challenge all of your assumptions from the very, very beginning, and even saying mental health, even using the terminology mental health, I think is something that in Zimbabwe we have found. We were challenged on that very early on, and we don't talk about mental health because mental health puts it into those categories that was so nicely presented there by Zikar and Catherine about, it really challenges cultural beliefs, and it really goes into many other realms of how people view mental health. Whereas when you're talking about well-being, there's an openness to talking about well-being. So I think that being very, very careful with terminology that we use in Ireland and are very comfortable with may not be the terminology to use when we're working. And so really listening for the cues, I think, is really important. In terms of mental health services as well, the issues, of course, say Zimbabwe and Zambia would be very similar in context. The issues, of course, is that there's just not enough trained mental health practitioners, and that's the reality. So again, having to challenge the way that we think about who could do who in the various levels, the various cadres of healthcare workers and community workers could provide what service. And there's a lot of interventions that have been developed that are, in our terminology here, task shifting, where they really are shifting the tasks to community healthcare workers and community groups to be able to deliver interventions that do require training and careful holding to make sure that fidelity and principles are upheld. But we've just recently conducted a systematic review of interventions specifically around stigma and HIV, which are all really in the mental health domain. There's a few that are really good examples of how community-based organizations and workers have been able to take on roles that in Ireland you would say, absolutely not, this has to be a very highly trained mental health practitioner. So again, I think just openness is really important. And trying to suspend what we think we know and how we say things is really, really important. Where did Brett's gone? We've lost her there. Anne, did you want to come in? I see the screen there around yourself. We've lost your video, Anne, and you may have meant that. And if you're speaking, we cannot hear you, just so you know. Not for now. No.
But Nadine, I might come in there again, because I'm very interested in what you're saying too, because I know that there were international studies done looking at the prevalence globally of postnatal depression. And there was one study that interested me from Harare. And but it started off by saying that there actually wasn't an equivalent word for depression. I think it was in Shona, right. And that really interested me, because language that we use and that's sort of taken for granted here.
Yeah.
When you realize actually that you may be speaking in a sense like a different language to the
right.
or people you're meeting, and also I think that it's very interesting. But the fact that I was looking at a publication recently, and it was about the way it was written, there was no consistency between terms like mental illness, mental health, mental disorders, mental problems, so we also ourselves have like we use euphemisms, and we do you see what I'm saying? So it's I found it very interesting. In other words, that for example, like we you know, when we see someone say who's very unwell, and we talk about they have a mental health problem as opposed to this is a mental illness, like, or you know, and also then the other aspect which comes out, which we don't see here really as much at all, but it's HIV related mental health problems. You know, so the different societies, the different prevalences. But I think your point about language, I think, is so relevant, and the need for us to be really tuned into it and listening and aware, you know. And so I thought that's an excellent point.
Yeah. Yeah, thank you, John. Anybody else want to come in with any thoughts? And as we kind of keep thinking, it's, you know, it's interesting, you know, we're talking about partnerships, institutional partnerships between, you know, people, you know, embedded in institutions in Ireland and people embedded in institutions in countries in the global south, and you know, trying to develop and support partnerships between those two institutions, specifically on mental health. So it's good just to start thinking about, you know, what are the challenges, what are the opportunities, what have we learned about the partnership approach itself, and then kind of thinking about that in relation to mental health. Maria, I know you would have, I'd really like to hear from you, just your experience with Londiani. You have a lot of experience in partnership, and, you know, it would be great just to hear a little bit. We never tire of hearing about the, you know, the opportunities and the challenges. If you're able to hear me.
Yeah, sure, Nadine. Yeah. Sorry about my camera, but the connection keeps being unstable. So I am listening, and yeah, I was going to offer some thoughts, I suppose. First, thank you to the two ladies for the presentation. It was very insightful, and like the previous speaker, we really could go through it in much more detail. I suppose from our point of view, just to explain to others on the call, so Brighter Communities Worldwide is an NGO, and we're based in Kericho County in Kenya. And we are, I suppose we facilitate or support the partnership between the two hospitals, and now in recent years also between Kenyatta University and NUI Galway, or Galway University. I always muddle up the names. I suppose the contribution I'd like to make is more from a community base here, and many of the points the girls highlighted in the presentation are relevant in Kenya as well, around the role of religious leaders, around the culture, very strong culture and traditions. I mean, even David's point about distinguishing between mental health and mental illness, it's not made here on the ground in the communities. We're very much a rural communities, and you know, the stigma that's around you know, both elements, whether somebody is ill or somebody is, you know, whether it's mental health or mental illness, is, you know, basically the person is mad. Now, what I would say is what's really coming to fore for us in the community, and we've designed a module in recent times for our life skills program, which is a community-based education program around mental health. There's bigger and bigger demands for it, and now the schools are looking for some assistance. At a national level in Kenya, the government, particularly during COVID, delivered some very strong strategies on mental health, and you'll see a lot of it in the media here and through our connection with the Ministry of Health. And it's interesting, even at our partnership meetings, and our next one is tomorrow, so this is kind of timely, at the hospital level here, people are struggling in, you know, the skills that the health workers needs themselves to deal with mental illness. And I think it's, you know, primarily it's skills, but it's also because they're also coming from the community, right? So the stigma, you can't underestimate the stigma that's associated to it. Not unlike the stigma that was around HIV and AIDS a number of years ago here either, you know what I mean? So whichever way partnerships are built, whether at the clinical level or the health system strengthening level or the community level, all of the elements will play a part. And it would be great to see parallel developments, you know what I mean, that the community level operates at the same time, or is kind of, you know, supported at the same time as the clinical level. And for us, our experience over the last, nearly 15 years now, is that when they operate in tandem, you get much better results. And, you know, the traditional, you know, mental illness healers can be brought into it. I mean, we've done it with the traditional birth attendants here, not with a stigma, as one of the speakers alluded to, but we did it by actually retraining the traditional birth attendants to become community health volunteers and birth referral agents, and now they're part of the program. And it doesn't happen overnight, but maybe something similar, like the learnings could be applied across any element, you know, whether it's HIV programming, whether it's maternal health, whether it's you know, even indeed in COVID, we had stigma here very much on COVID as well. So yeah, there's just some things to think about, I guess.
Thank you, Maria. I think that's really such important points around stigma. And I hear from you, and I have that same experience. Like, you cannot emphasize enough the stigma around mental health and mental illness. And I think your experience, it's wonderful just to have your experience. And I think for John and Anne, Kieran, I'm not sure where you're at, but just to know that there are people who've been, you know, doing this kind of partnership for a long time in similar areas. You know, the one of the ideas of this partnership clinic is so that people meet and you can reach out independently and just ask, have you got something that a little bit more on that? I'd like a little bit more on that. I see there's a message in here from Hibberet here saying her connection unfortunately is bad. Congratulations again to the presenters. She echoes John's comment about where to start, local partner being on board and identifying the needs critical to get partnership. Ethiopia has been lucky to some extent to have developed psychiatry training the last 20 years, but the needs for a population of more than 100 million remains outstanding. Yeah. David.
Yeah, no, I was just going to come in there because Hibberet got cut off, and she sent the message, because Hibberet is leading our HSE partnership with Ethiopian mental health, and she's a consultant psychiatrist working here from Ethiopia. So she's got some very good connections back to Ethiopia, which is very valuable. And I think, just to echo the points that she's making, that I think what's been so important for us is in our engagement with them has been able to engage with stakeholders and to hear from them what the needs are. So that came up during COVID, during the pandemic, when we approached the ministry and we asked them if we could we had some resource to support the mental health of health workers working on the front line of the pandemic. And they came back with identifying this opportunity to support them with training and workshops and developing videos to improve or to strengthen resilience, emotional resilience of health workers. And that was a very effective project. And now we're following up, and you know, the way on our follow up to that was to ask them, well, what can we do to improve mental health services in Ethiopia? So we're responding to that, and they've come back to say they don't have a partner in the area of clinical psychology. So we're going to do something there, as well as continuing the work on emotional resilience. But I think for us, I think the important thing is always about listening to them, hearing what are their priorities, responding to that. And then I think once you build the relationship, then you can start suggesting other things maybe that might be useful. I see Hibberet is back, so maybe I should stop talking and see if she would like to speak.
Hibberet, you're muted, Hibberet.
You're on mute.
Sorry, my connection has been bad.
It's good. We can hear you loud and clear now. And we made your first point already. So we've benefited from your first point, but we'd love to hear from you. Any thoughts, ideas, particularly around partnership itself, and how has that been? I mean, it's so important for us all to learn. How has that been? How has the process been? What are the challenges for you? What advice have you got for people about trying to get into partnerships?
Well, I don't know if I have any advice, but the one thing that I've seen and learned, from the global health and David and Tora is unless the local partners, unless they have a big buy-in, it's so hard to get anywhere. And I know because, when I do go home on holidays, there's a lot of talk, but essentially if people don't have, the interest to sort of form partnership on the local ground, it just doesn't come to anything at all in my experience. And I think from Ethiopia's perspective, my own experience is there's a huge need. Like the population is more than 100,000 population. And really well done to the two presenters that tried to gather data, because I can imagine it's a very hard work to gather data. The data that is there is probably very minute and perhaps not easily readily available and does not probably represent the whole population. So to make some sort of sense out of it, really well done to the two presenters. So where to? I think, there are systems already in place, but the sort of maybe the local partners need to make the call, I suppose, in terms of where best they want the partnership to be in. And that's when it works. When I think it works is when the partners make the call.
Yeah, very powerful, and yeah, such important. Thank you. It is good advice, and thank you for giving that. And I think, here, Bernette, when I hear that, it's like we kind of sometimes we know, like we know that it's like, make sure it meets the local needs, make sure it fits with the locals. But what that means is, all of us are so passionate. This is what I've seen from my experience in partnerships. Each of us come in with, as individuals, with, you're passionate, you're dedicated, you're experienced in an area, and you want to just share it. It's such a lovely thing. You just want to share something that you think works and something that is wonderful. And then it's sometimes that becomes, it kind of absorbs that really important question. Here's a little bit about what we've got over here, and what can we do to support you? What do you need? And then sometimes listening, it comes back and it's not what you thought. In fact, most of the time, it's not what you thought. I'd almost say to people going into partnerships, imagine that you're going to go there thinking you're going to do this, and you're going to come back and you're going to be doing this. And then there's no surprises. I don't know, David, I think that's probably the case in many of the ESTHER partnerships over the years. That's what we've seen, which is why the whole process of developing the partnership, which is why ESTHER is really there to help you develop a partnership that lives by those principles, reciprocity, really listening, building trust in a relationship, suspending your own views. Yeah, really listening. Kieran, I know that you had a question around language, then thank you so much for those of you who posted questions beforehand. But around the language barriers, such an important question. I don't know, Kieran, are you in a position to say a little bit more on that, and we can lean into the wisdom here in the group? I think Kieran might be on the go. And if anybody wants to just step in there, language barriers, what have we learned? What can we say about that?
Yeah, I mean, if I just jump in on that, one of our partners, sorry, I'm going to have to step out. My doorbell is just rung, so just excuse me. I'll come back in 1 minute. Sorry now. No worries. Yeah, language barriers. I mean, what have we learned? Tara, I'd even come to you, your experience in Ethiopia. What are the this kind of, what are the basic things that we've learned that we, what would you say about language barriers?
I think with Ethiopia, there's, a lot of people that we're engaging with have, quite good, English. I think it's around the cultural piece. It's the engagement, I think that you made a very valid point, Nadine, about how, I'm new to global health, where you want to go in, you want to get engaged, you're very excited about it, and understanding the culture to go at their pace. So I think for me, the learning has been, let them drive the pace. Now, I'm, come from a different, emergency background, and I feel as if everything should get done straight away. And, so I think the learning for me over the last year is to be guided by their pace. So not so much around the language barrier, but certainly in terms of the culture, understanding their culture. And I think that, I suppose having the benefit of working closely with David to understand, he's like, not do it for two, it's to do them with. But
Yeah.
then the second part of that is, you know, being guided and going by their pace. So for me, that's been huge learning for me in the last year.
Yeah.
Because I think initially when you start on something, you have that enthusiasm, you want to get going, you want to get started, you want to do for them, with them, at them, to them, you know. And I think it's the whole key learning is be guided by what works for them, you know. And part of that is the cultural piece about them coming back, or, you know, and that even around with Mozambique as well, although it might be frustrating from my perspective, I think it is a huge learning.
Yeah,
as well.
Thank you. Thanks, Thor. I love that. You know, you just suspend what you think in terms of pace. You don't know the pace it's going to go at. Cara, what about you? What's your experience?
Yeah, I think timing really is such an important issue, and maybe a little bit to echo some of what Thor has said, but also if we're talking about partnership, we're talking about long term. If we want it to be a quality partnership, we're not talking about activities completed within a particular time frame. We're talking about establishing and building a relationship over time. And if the way that we establish that relationship is based on that mutual trust, based on really understanding and listening to what the partner wants and needs, then those activities will come in their own good time. So really just kind of emphasizing that. In terms of the language barrier, it's kind of an interesting one. I suppose it depends which country and where, and the levels of language ability that people have. But I think obviously, you know, there's the potential to use translators in some situations. And I think these things always need to be done with just a little bit of caution as well. That sometimes, even when we're speaking the same language, that, you know, we're actually saying different things. So with, you know, obviously then when you're adding a complexity of a completely different language, I think it requires more checking in, more kind of confirming that we really are going down the path that is being led by that partner. And obviously then there's plenty of tools that we can use, and sometimes, you know, things said and then like backed up with that written communication where people can go back and refer to it, and, you know, use tools such as Google Translate or whatever. But I think it's just an extra level that to be mindful of, and apply some level of caution and careful consideration, because we're not, sometimes we think we're saying the same things, but we're not, and we need to just be really, really careful.
Thanks, Cara. David, you wanted to come in there probably about Mozambique, was it?
Yeah, thanks. Sorry to drop out there. Yeah, just a few thoughts came to mind there. Yeah, the first was in relation to language and Mozambique, where we work with a Portuguese-speaking country. And for some years we worked well because our kind of key relationship was with someone who was fluent in English. Then that person moved on, and the person who came in and replaced her wasn't confident in speaking English. And that becomes a real issue if you're working online. And a key part of our solution was to get someone onto our team who spoke Portuguese, and that's someone from Lisbon University, who's both a subject matter expert in the area we're working in, but also speaks Portuguese. And I suppose the point here is partly that just communication is so important, and it's not easy when you're doing a lot of it online. And so if you've got the added thing of language difference too, that's very challenging. So I think it's finding ways to enhance the communication. And I don't think we could be carrying on working with Mozambique without having this person in our team from Lisbon. And I think that will continue to be important. And just a couple of points out about language. I was, Cara will know this because we were both at this event in Geneva recently on partnerships, on equitable partnerships, a side event around the World Health Assembly. And the Minister of Health was speaking, the Minister of Health from Uganda was speaking, one of the keynote speakers. And she was referring to COVID and said, during COVID, our partners deserted us, or abandoned us. That was the word, abandoned us. And it was quite kind of an interesting perspective to hear how she saw partnership during that time of crisis in relation to COVID. But really, but what I want to pick up on was some of the things she said about language, that the language that we use, that we don't realize how it communicates in other contexts, like north-south, who's on top, who's on the bottom, developed countries, developing countries. So are we developed and they're not? And it's language that we've grown accustomed to using that is very unhelpful if we're trying to engage in equitable partnerships. And I think I was very challenged by that. And I think it's something I think always be reflecting on is the way where the language we're using in our partnerships. And just on that kind of whole idea of, I suppose, of the power imbalance in partnerships, something that came up this week, and I won't say which country or which partnership, but someone phoned me yesterday to say that this country, where they're working with an institution, that the people from the institution are coming to Ireland, and that they were discussing it with the Ministry of Health, and the ministry decided that they would send 5 people. Or there's this discussion going on, and so what do we think of this? And my reaction to that was, well, who makes the decisions around this? It shouldn't be us. And that is what's important, is go back to your partner, and that they, if we're in, it's an equality in partnership, they should make decisions. And it's not for us to second guess why do they want to come and all of this, that we need to see what equality really means when it comes to making decisions, and that we don't start saying, well, we're happy for them to do one thing but not another. It's that care we need in how we, that we're not dominant in terms of deciding around things.
And I think, David, that whole thing of power, there's a lot of discussion. Sometimes you listen to this and you think, oh my God, but what am I supposed to say? And how do I know what's the right thing? And that can be quite paralyzing. And I think for me at the moment, I'm thinking, if you just think of power in all of your conversations, just think about, where is the power dynamic? Where is the potential power? What, let me think about this in terms of power. That's helpful, just to orient yourself, because it's not easy. In terms of language, I also just wanted to flag that it's not just language between Ireland and a national language like Portuguese in Mozambique, but for instance in Zimbabwe, you develop something in English and then it needs to be able to be delivered and translated into Shona, but then of course it also needs to be delivered and translated as it goes out into rural areas into other languages like Entebbe and the other 15 languages spoken in a particular country. So thinking bigger, really understanding the context of a country and what people want and where partners want to see these skills, this training move from the outset, I think is important. And in terms of, what you were saying, David, about the minister in Uganda, being responsive to needs, we have an example here in Ireland of one of the ESTHER partnerships, the Gori-Malawi partnership. I think it's really good to be specific with partnerships, how, that partnership was moving since May 2016, and it was working on non-communicable diseases in some specific areas that had been well identified by the partners in Malawi as important local needs. And then COVID happened, and they asked the question, what do you need? What do you need? And the partners were very clear. We need information on COVID. We need videos that help us understand how to manage healthcare facilities, how to support people in the healthcare facility. And so they completely changed the direction of the partnership to be able to respond to what was needed in a particular time. And I think that's very relevant. If you're looking like countries like Sudan, for example, where things are happening and changing what priorities people have. And as a partnership, are you ready to respond to that? Are you ready to stay with the partners during all times in the way that they see fit? I think that's really, really significant. There were other. Anybody else want to come in? Anne, you're also welcome. Yes, we'd love to hear your voice. And
yes.
Yeah,
one or two thoughts I have. With a couple of start with regard to, say, partnerships, and somebody very wisely said there at the start, the partners need to make the call. Well, could I go a step forward and a step beyond that and see if anybody has had this experience? But I think waiting for the partners, and this is after the relationship has been established, of course, but I think then my experiences and my hunch is that we also need to be innovative and creative and imagine ourselves in their shoes, because that then allows us to maybe identify an area that may be of interest to the partners, because it's hard for them to pick out of the ether something that we could fulfill, because they're not in the country, the more developed health systems that they are. So it's hard for them to identify something that could overlap and be of use to them. And I think that's a big challenge, because they might, that we are ready when we meet the partners to say, well, I wonder, would this work, or would this be something that would be useful, and see where it goes. It may not be, but I in my experience of talking in that situation to the other members of the partnership, I've sensed a sort of, I need to come up with ideas as well. They can say no, as I say. So that's one thought. I don't know if anybody else would have had that experience. The other thing would be language. I'm sort of partly involved in developing a new sort of approach with regard to a partnership with mental health in Malawi. And I felt quite daunted, because having sort of worked psychiatry, I have worked a little bit in psychiatry, but more recently in psychotherapy, and language is all important. And speaking the language of the person who is the patient or the client, one has to listen so closely. But then if there's a language difference, when, say, in psychiatry or in psychotherapy, you're going to have to rely on a translator, and you're going to lose quite a bit. So the translator or the maybe clinical officers, their skills have to be perhaps supported so that they can pick up the subtleties that allow you make a diagnosis. So that's the second point. And the third thing is around stigma. And before I went to Malawi, I read up about what I could about mental health and Malawi. And I was really interested to hear that younger people in Malawi, it's been reported, have much less of a sense of stigma. It's more the parents and the grandparents that have this bigger stigma around mental health. And the difference has been that social media apps are now for younger people, are talking about mental health issues that were not talked about very much, perhaps, until now. So younger people are losing that sense of it being such a big stigma or being so different, because they hear other people on social media talking about their mental health issues. So I think there's hope there. And of course, social media and phones are now so much more available to a very high percentage of people, even in poorer countries, that there is, there's definitely an avenue there to work on the stigma going forward.
Yeah, thank you, Anne. Some really, really important, great points there. And Hibernette, you're probably going to come back in and respond to some of those points. We'd love to hear your view.
Thanks, Nadine. Just to comment. Yeah, thank you, Nadine. Just to comment on the language and the communication with different languages and maybe cultures as well. So maybe just to say, the language, the words itself may mean something, whereas the culture of the way it was said may imply totally something different. But not to be afraid and to ask and inquire what exactly is meant, maybe the way to sort of go around it. Just, as a matter of a joke, there is a video clip that myself and my husband watch. If it's about one of our renowned, Ethiopian athletes, and he's asked after winning a race, will he run for the next, Olympics next year? And his reply was, God knows. And, to me, I would interpret that, of course, he's running, he's going to run it. There's no God knowing. But that was the language he chose to communicate in it, and maybe to understand and ask again, and not to be afraid, as you said, to take innovative approaches to bridge that language and cultural barrier, to understand what the partner says, because it's a learning process for the partner as well. And partners want to learn. and want to get engaged in the process. So to be brave and ask, and yeah, take it, understand the culture as well as the language.
Mm-hmm. Thank you.
And as relates to stigma, absolutely, you are spot on. I think stigma is still huge, but these days, certainly what I see from countries like Ethiopia is, you know, the private industry is also quite flourishing. So stigma is particularly in the cities with the private psychiatry services and mental health providers. Stigma is, you know, it's becoming less and less, purely because the private services promote, you know, your mental health, you have to look after it, you have to get treatment. So it has that type of effect these days. But then again, it is only in the cities, and the countries are huge with a lot of rural areas for majority of the African countries that have been mentioned. But certainly in the rural areas, I do see stigma being tackled through the private services mainly.
Thank you, Bernadette.
Thanks.
Thanks so much. David, I see your hand there, and if I can also add to what you were going to say, there was two other questions you might just want to say something to. One of them was, you know, the role of an MOU. Why is a memorandum of understanding important in terms of partnerships? And the other is, how does ESTHER Ireland relate to Irish Aid?
Okay, I can think about those as I'm making my first few points. I mean, I thought that Anne's kind of raised some very good points there, and they just sparked a few thoughts from me. And like Anne, you spoke about sort of being innovative, and I think you know, taking initiative. And I always find this a constant dilemma: is when do you take initiative and when do you wait for the partner to take initiative? And the danger is if you wait for the partner, nothing might happen. And it's yeah, there's always a tension there. And when we started our work in Mozambique, we didn't do any technical work for 2 years because I didn't feel there was enough clarity from their side of what they wanted to do. And so sometimes you do have to wait. But there's also that point, I think, and you were saying this, Anne, that maybe the partners won't always clearly articulate what they want, or may not be quite clear what they want from us as partners. And so they're a little bit while waiting for us to tell them what it is we think we can do to help in their situation. And that's very much where we're at now in our partnership with Tanzania. And we just started there in November. The ministry wants us to collaborate with them. And they're very clear about one general area. They say they want to improve quality of health services. So that's clear. But they keep coming back to us and saying, now, what are you going to do to help us with it? And we keep going back to them and saying, what do you want us to do? And we're trying to tease that out. And that's a tricky one. And I suspect that what we'll end up doing is we'll go out and we'll do a capacity building workshop that we think is kind of what they're looking for, but we're not quite sure. But we want to get on and do something with them. And through that process, we'll figure out what it is the best thing to do. And it reminded me of something that was said again, this side event in Geneva recently from the WHO representative about this, of how do you raise issues with your partner if you want to challenge them on something or suggest things. And she said, first build a relationship and then you can have the dialogue. And I think that's a very helpful statement. And I think that's probably where we're at with Tanzania, is we want to get into that relationship where they feel they can trust us. And then we can start asking questions or suggesting things. Because like when we go there, we see, oh, look at it, they have a huge problem of non-communicable diseases. It's just rapidly developing. But they're a little bit maybe slow, you might say, about responding to it. So we want to raise that with them. But we don't be telling them they need to do this or that. But when we have the relationship with them, we can put that to them and say, well, maybe that's something to think about. And so I think as we develop the relationship, then we get those opportunities. And we're seeing that already by going in with the right approach. They're sending us some of their draft strategy documents. And the embassy is saying to us, they never share those documents with anyone. Why are they sharing them with you? I think it's because we've gone in, not with our agenda, made it very clear. We just said, we want to partner with you, and they feel comfortable to share them. So I think by building the relationship, then those kind of doors open.
David, just on that point, because I know you have a number of points to make. I think one thing we've learned in the ESTHER partnerships, which is really important, is that our partners come to Ireland and visit our institutions and talk to people in our clinics, in our hospitals, in our organizations, so that they can see, and exactly what you're saying, they can see some of the things in action, and then they have a better picture of what's possible in their context. So in the ESTHER grants, we really encourage that there is a reciprocal visit, particularly as partnerships are being formed, because to think that we can go to a country and share everything and then people will know what's possible is very one-sided of us. Just like we need to go there to understand, they need to come here to understand. David.
Yeah, thanks. Yeah, good point. Yeah, just your two questions then. The role of an MOU. Well, I think we strongly encourage partners to formalize the relationship, and usually that's by an MOU. I mean, there's other ways you can do it, but MOUs they can be very, very helpful for providing clarity around the commitment on both sides, around what are the shared vision and objectives on both sides. And I think how the partnership is going to work, and to set it out in a way that clarifies how it works on the basis of equality, by how decisions are made, how communications will happen. And it can be a very, very good foundation then for whatever work is done then through the partnership. And so it's just, I think, very, very good to have that clarity around the way the partners will work together. So yeah, we definitely encourage that. And I think from the Irish side too, by having a document like that, it's a statement of an institutional commitment. So if you're working in a hospital here or whatever institution you're in, an MOU from your institution is really saying that this is not just work that you're doing because you're interested in it. We're saying that we're seeing it as part of the work of our institution. And I see that with some of the hospitals, where the hospital signs an MOU and they're saying this is part of the work of our hospital or our hospital group, so that when individual staff are involved in the partnership, it's not something they have to do in their own time always, or that's just their own interest. It's actually part of the work that the hospital is committed to doing. And that really makes it a much better way of working together with the partners. And it also fosters multidisciplinary team working, which is again another strength of the partnership approach. The other thing you mentioned about the ESTHER Ireland and Irish Aid, well, I've had the opportunity, as Tori did as well, to attend a meeting just last week of a workshop, a 3-day workshop that Irish Aid had on their policy, A Better World. And it wasn't quite a review of their policy, but it was a reflections on it and just consideration of whether they're still holding to this policy and will they want to change anything. And what in the workshop they reaffirmed a commitment to a better world. So I think if you're working in partnerships, I would strongly encourage you to read Ireland's international development policy, because I think the work we do in partnerships fits right into that. And among the things, just a couple of things that struck me very much from the meeting. One was they spoke a lot about reaching the furthest behind first. That's sort of their catchphrase. Oh, I don't know if that catchphrase was the word, their slogan. And with the Sustainable Development Goals, we talk about leaving no one behind. Reaching the furthest behind first is really a statement beyond that, saying that not just about not leaving people behind, but proactively trying to reach those who are behind, who are furthest behind. And it was good to hear that, because during the pandemic, you wondered what the commitment of Ireland, as many other countries, was to the lower income countries. Because when it came to things like vaccine rollout, they were certainly being well left behind. And so what did that mean for international development policy? We were saying reaching the furthest behind first, when actually the furthest behind were last when it came to getting COVID vaccines. But so there is that commitment is genuine. And what I think it does, a lot of the work we do in partnerships is about reaching the furthest behind. We're talking today about mental illness. People who have mental illness are being left behind, not being served. And there are other examples of different partnerships that are involved. People are involved in leprosy in Nepal, people with albinism in Malawi. You know, these are people who are absolutely being left behind. And that's, I think, one of the values of the institutional partnership approach is you can address some of these areas of health need that wouldn't be addressed otherwise, that are not being met. And so definitely what we're talking about today is one of those areas of reaching the furthest behind first. And so I think we should be very comfortable with doing it as part within that umbrella of Ireland's international development policy. And one of the things I think the challenge for us then is also to be communicating that back to the people we know in Irish Aid and Department of Foreign Affairs, that we are really helping them implement their development policy through the work we're doing through partnerships. And they did also reaffirm the partnership approach. That means different things to different people, but I think we are at the forefront, I think, of really thinking very carefully what it means to be a partner and how that works out in practice. So hopefully that's also the way in which we're working that's contributing to the development policy.
Mm-hmm. Thanks, David. And just to say, in terms of the relationship between ESTHER Ireland and Irish Aid, is that Irish Aid and the HSE have a service agreement, which is really to support work on partnerships, partnerships between Ireland and other countries, partnership between Irish institutions and partners in the countries, particularly the priority countries where Irish Aid operates. So that's really the direct relationship there.
Yeah, maybe just, yeah, no, I think that's good you said that. Yeah, no, yeah, that just in case, yeah, any people were wondering, where does the funding come from for ESTHER grants? The answer comes from Irish Aid and Department of Foreign Affairs.
Yeah.
And we hope that that funding will grow, and that as it grows, we will make more funding available for partnerships. And one of the questions for us then within HSE and with the Irish Global Health Network is what's the best way to support partners? How can we support partnerships to be effective? Where do we get the most impact and results? So we're looking at that as we proceed. And you might have seen the call for applications that came out recently, and we talked about partnerships to strengthen health systems. So we're encouraging partnerships to think about how their partnership is contributing to the health system and how it can have an impact as the highest level of impact.
Mm-hmm. Yeah, I mean, does anybody have any other kind of, I don't know, questions, even practical questions on partnerships or how to move forward, or anything you think, oh yeah, I think I'd like to share that from my experience of partnerships? You know, you're very welcome as we kind of move into the last part of the meeting. And I know at the end, Cara will share with us a little bit more about, you know, what is ESTHER, what's it there to support, a little bit about the grants. But just before that, any other thoughts or questions or comments?
I just make a comment, Nadine, as well, because I mean, having worked, say, in Zambia for 2 years now, many years ago now, but the legacy of colonialism was very strong, and like in the small shops in the area where I worked, I mean, you know this probably yourselves, but up to independence in '64, a black person couldn't actually go in the front door of the shop. They had little hatches at the back where, so there was apartheid there, and that was only like up to 1964. So there's a big colonial shadow, in a sense, I think, in many of the countries that we've talked about there, and I also think that, again, if we think about, in a sense, emphasizing partnership, and what I might describe as, in a sense, like a donor mentality. In other words, we've talked about we buy into partnership, but actually I think the piece that's missing is what I might describe as the recipient mentality. Because if you think of any of us, and probably because a lot of people here and people who get involved in this sort of work, they have, in a sense, like what I might call it, the donor mentality. But the donor mentality requires the recipient mentality as well. And it's and I, like, in other words, I think often if we reverse it, we look at say, if the US decided, or if China decided tomorrow that they wanted to come into Ireland and do X, Y, and Z, what would our response be? You know, what would our reaction be? And, you know, so I think when Anne mentions it again with her interest in mental health and from a psychotherapy point of view, I think the psychotherapeutic dimensions of this are actually very important because, you know, as I said, you know, we can think about the donor mentality, but the recipient mentality, and maybe if it was reversed, I mean, I just wonder, you know, how good are we at being recipients by saying, oh yeah, I want this, I want that, I want the other. Are we typically Irish and says, I know we're grand, you know? So it's you know, so in other words, I think there's lots of different factors come into play when you look at developing a partnership, and not necessarily the obvious one.
I've often thought about that one, John. You know, it's a partnership, and it's obvious that when we're the donors are and I think the UK have sort of encountered that as well. You know, they want it to be more of a reciprocal benefit to both parties. And I often think about what do we get out of it? You know, if we become, and I've worked actually in Nigeria, like yourself, for years ago, for 2 years actually in a general rural hospital, and there was no such thing as a psychiatric hospital, as there still isn't, I think, in very many parts of, well, I can talk about Malawi anyway. I think there's 3 psychiatric hospitals for a country of 18 million people, and approximately 4 to 5 psychiatrists for 18 million people. And I was lucky enough to go as part of the Gori Malawi trip in March, but I was lucky enough to be able to visit this psychiatric hospital while there. Sort of getting off the point a little bit, but yeah, I think my point is yeah, how are we get a lot, you know, we do receive, actually, you receive in some way by being involved, being allowed to be involved, by being invited to help in some way, or allowed to be part of their health system, even in a small capacity. So I think we do receive a lot. And reading up about, say, the UK relationship and partnerships, and they make it very clear that they list out all the ways that they receive. I remember reading it a year or 2 ago. They receive in terms of visits from the partner country, and how that enhances our health system. Just knowing the contrast helps us, and sharing what we do, you know, helps both. But anyway, just to get back to my point, I'm of the feeling that one way that kind of stands out to me that we can help in supporting mental health in, say, Africa, is by supporting education in mental health. And if we're thinking about helping those left farthest behind, i.e. those who are symptomatic psychiatric patients, the care they get often is not well, you know, not very, very well informed, and it's the very best that can be offered in the circumstances. But with more education, I think that's, to me, how we could support in a very substantial way, by supporting those who are delivering the service. And it would require quite a bit of relationship development, partnership development, and being open to their needs, and also trying to be innovative, because that would reach perhaps the clinical officers who are in the outlying district hospitals where there are no psychiatrists. I think there aren't psychiatrists. There's no psychiatrist. There's only a shared psychiatrist in northern Malawi between the capital and the north. So it's down to the clinical officers. So if they have you know, if we could somehow strengthen their you know, their education, their experience of mental health issues, we're going to be reaching those who are in outlying places, who wouldn't ever have probably the funds to come to the city for psychiatric treatment. So it seems to me that would be a significant contribution to be invited, or to be allowed to support the education that they're already receiving.
Yeah, thank you, Anne. Some excellent points. And Maria, you were going to come in there just before as well.
Yeah, sorry. No, I was going to come in around the MOU side of
Welcome,
things.
welcome. Keep coming in. Everybody,
Can you
all
hear me?
ideas. Yes.
Yeah. I was going to come in around the MOU as David was speaking and connecting it to the relationship building. I mean, for us, the MOU process actually strengthened our relationship because we got to discuss all the different elements, like what happens if this happens, what do both parties want, and then when we expanded it out, we had even more conversations. And I think it actually helped with the equality in the background, you know, having these conversations and accepting that, you know, I suppose here, you know, the global, the partner in Ireland is called the Mzungu, really, right? And then you have the local, but like then on the other side, like the COVID pandemic here was our biggest equalizer ever. The biggest equalizer, the biggest confidence builder of the team here. And we have over the years seen the reciprocity in Mayo Hospital through the kangaroo care and through lots of innovations in their maternal health and how it's delivered in Mayo, which came from Londiani, and they're well documented. So I think all these processes, whilst, you know, sometimes they sound theoretical, it's the actual going through it, and it never takes a week or 2 weeks, it always takes longer. But that's all relationship building. It all helps with language, communication, and the equality piece, which we'd be very strong on. And it probably requires as well a lot of patience. You know, we come from it from a different mindset and a different speed. I don't know which speaker was speaking about the speed from the emergency department. But you get there in the end, and then you end up with, you know, that you can have the hard conversation. So for us, just to give an example, our next triennium is all about perinatal mortality here in Kenya. And, you know, 10 years ago, quite honestly, people wouldn't even talk about it because it's stigma again in the community. There's shame around for the women, but also the health workers dealing with the high mortality rates, their whole stress levels, their mental health, everything. Now they're starting the conversations, and I honestly don't believe 10 years ago we could have started. I think you have to build it slowly and on the relationship, and it's all around people. You know what I mean? So, you know, sometimes you think it's taking a long time, but the results are very much shared across the partners then when you take that time and just, you know, be patient, you know.
Thank you, Maria. And I think somebody else said as well, I mean, partnerships are long-term. Projects are short-term. You can easily, you know, come up with a project and a set of activities and you get the funding and you implement and it's over. But partnerships are about long-term. And so, of course, it makes sense that it takes time. And I know years ago when our first ESTHER Partnership Forum, there was a presentation, we presented something that compared, you know, to a partnership like this with a partnership between two people, in that it's no different, in that it's especially at the start, you're dating, you are going, so like John, for you guys are going out on a date and you're going to meet, you know, it's a blind date in some ways, you're going to meet some people on your date, and you know there's an attraction that happens or doesn't, or there's red flags, or you know there's red flags happening, and it's an opportunity to listen to your instinct about that relationship. And one of the things that we class in ESTHER as a successful partnership is a partnership that doesn't go ahead after the initial dating, because they have really seen that they just don't, they don't connect. It's not the right fit. It's not, and all of you know, all of you have been in relationships where you've been with a person and it wasn't the right fit. And if you haven't been in one, you've heard of somebody who was in a relationship where it wasn't the right fit. It's not great. It's not great. So, you know, getting the right fit, dating, taking your time, exploring things, and trusting that if it's not that group or that partnership, maybe it's somewhere else. And again, maybe I don't know. I think it's going to be that hospital and that group of people, and who knows, right? So dating is really important. I wonder, as we come towards the end of this clinic, if there's anybody else who'd like to say anything. Hibernette, I see you there, and I'd love to hear if there's anything from you, kind of final comments, and then David and Cara, if that's okay. Hibernette, any thoughts?
It's been really enjoyable to have this clinic and listen to everybody's, yep. Can you hear me?
Yep.
Can you hear me, Nadine? Yeah.
Yep.
Yes, yeah.
Oh, I was just saying it's been great to listen to this clinic and hear everybody's viewpoint, and really learned a lot about the dating aspect of projects and long term, because it could be frustrating waiting. So knowing that it's a long term relationship, many years of partnership and patience is required. It's good to hear that is the way it is. Because sometimes it could be very frustrating, the wait and the decisions really could be frustrating. So it's good to hear that it requires patience. And maybe as well, the memorandum of understanding really critical so that everybody's on the same page about what that project and that partnership is going to look like, and be given the opportunity to review it and contribute to it from the partners from both sides is really critical. And then maybe in that memorandum of understanding, it comes to a point where the final and the critical decision makers are identified. Because when you do go out to a country that you do not know and you do meet people, there could be layers of decision makers, but the final critical decision maker probably comes through the memorandum of understanding, because it is binding. So that's all I wanted to say, and it's been great. Thank you so much.
Super. Thank you, Hiberet. David.
Yeah, thank you. And just reflecting on your last comments, Nadine, I seem to be in multiple long-term relationships that at this point are probably more like marriages. And does that make me a polygamist? But that's another discussion. But I think the analogy is good. I think there's a lot of parallels. There were so many good points for discussion today, and just I suppose just add one final point, that I think and it really follows maybe Anne's comment about training. I think that's where the biggest opportunities are in many ways. We're not going to go out and be able to impact on ourselves on large groups of people, but if we can impact on programs that are going to reach large groups of people, then that's going to be really impactful. And opportunities to engage with training programs and strengthen them, there really can be very fruitful. And just one point there is about, I think what's going to happen, we're going to see a lot of the growing opportunity with digital technologies for online training. And I think we're going to see more and more of that. And I was speaking with someone yesterday who has developed an online course to train biomedical engineers. And I thought that sort of training, equipment maintenance needs to be sort of more hands-on, but it's proving very, very successful. And these are people from low-income settings, mainly in Africa. So I think that's something for us to keep in mind. We need the visits sometimes to build the relationships, but when the relationships are established, a lot can be done online. And increasingly, we're going to be challenged about that with climate change, not to be traveling more than we need to. And I think we'll find there's opportunities for a reach and scale through online training. So that's all I'd say. I think it's been very useful. I've been enjoyable listening to people, and I just feel I've learned new things, and so that's appreciated that. Thanks.
Thank you, David. Anne, yes, of course.
Will we have a follow-up in a couple of months, or was that planned? I know you have different areas of support for partnerships in different fields, but I just wonder, is there maybe a place to think of following up with this group even in a couple of months?
Great, and I love your thinking, and that's actually perfect to hand over to Cara, who is the ESTHER coordinator. And Cara is just going to tell us a little bit about, just to make sure everyone's aware of what is ESTHER and the the support that's there for you, and also perhaps you could add in, Cara, a little bit then about other partnership clinics and how how support can be accessed. So over to you, Cara.
Sure. Thank you, Nadine. Yeah, I think exactly that, just to kind of, we've mentioned so much already today about what ESTHER is without maybe just sort of explicitly saying it. So maybe just to be really, really clear, I'm just going to cover who we are and what we do and how we can support you moving forward. Some of you will be more familiar than others with that kind of support, but basically we're ESTHER Ireland. I'm the ESTHER Programme Coordinator, and the ESTHER Programme is an initiative of the HIV Global Health Programme. The HSE Global Health Programme, and the Irish Global Health Network acts as the secretariat for the programme. And really what we do is facilitating and supporting Irish health services and institutions to develop partnerships with counterparts in institutions in low and middle income countries. So these institutional health partnerships, as we've talked about plenty today, are these long-term institution to institution partnerships, where the focus really is on strengthening health institutions in order to improve those health service delivery and outcomes. So the focus is so much on strengthening that relationship, strengthening that partnership, so that the delivery of the services and outcomes can be positive in the long term. The type of support then that ESTHER provides can be technical, networking, grants, and also kind of a quality partnership approach of support. In terms of technical, we organise learning events such as the annual ESTHER Forum. We regularly share resources such as through our newsletter, Partnership Panorama, and you can sign up for that newsletter on our webpage. Perhaps Maisie will just put a link, if you don't mind, into the chat there for the website. And then other technical support such as this clinic here today. So this clinic is a part of a series of clinics. We decided we'd run this one first in the area of mental health before we plan and name what the other ones are. But in a few moments, you'll have a chance to input in to decide what other topics we can cover and where else perhaps people would like to have this type of conversation and this type of technical support. In terms of networking, we connect with health partnerships, we share learning with other health partnerships, and bring together those that are working in this way in partnership, including at times partnerships that are maybe operating at a more global level, at a higher level than ourselves. We have a grant round which is currently open that I think probably most of you are aware of. So the grant round is providing grants of up to €8,000, and that can be applied for any time from now up until the end of the first week in July. And these grants are for new or established partnerships, and full details of those are also available on our webpage. And then in terms of, I think really like a lot of the conversation today has been so much about not necessarily specific to one theme or topic, but more generally, the foundation for everything that we're doing, whether it be mental health or other program areas, is very much in terms of quality of partnership. And this is where ESTHER has a whole body of work that's been, I suppose, brought together over a period of time. So quality of partnerships, there's the ESTHER principles of quality partnerships, and they're also available on our website to view, and they look at the different, I suppose, characteristics of what it means to have a quality partnership that will lead to that sort of longer term positive outcomes. We also have a tool called the ESTHER Effect tool, which is a way of working in your partnership and examining some of that power dynamic, really. Who's making the decisions, who's involved in those decisions, and really can provide a very practical way of moving your partnership forward in a really good way with a dynamic that is more equitable. And then finally, really, we have also ESTHER accreditation. So this is a way for us to honour partnerships who are adhering to these principles and are working in a way that's exemplary in terms of partnership. So that's kind of it in a nutshell. What I would finally ask for today is, as I mentioned, that we will be running more partnership clinics along the same format as this one here, but they can cover other different topics or themes. It could be a geographical focus, or just other themes that your partnership is working on or would be interested in working on. And again, it'll probably bring together a slightly different collection or group of people and partnerships. again, sort of an opportunity for networking and learning there. So Maisie will put in the chat the link, if you don't mind filling it out, for our feedback evaluation form that gives you the opportunity there to tell us how you found this experience today, and also to make those suggestions for other areas that your partnership might benefit from. So I think that's it. I thank you all for participating as well. Just from my perspective, it's really lovely to get to know the partnerships a little bit better. So thank you.
Thank you, Cara, for all your great work. David, do you have a last word?
Yeah, sorry, just a very quick. Yeah, today we focus on mental health, and there may be an interest for people to have some kind of group for networking around, particularly around mental health. And I think it'd be good to hear your feedback on that. It's on something we're considering within the HSE, is how do we bring together people involved in different mental health initiatives. We had a project group that Hibret has been leading for Ethiopia, and that's been very valuable. But if that's an interest of people to have something, a thematic group, being part of something in mental health, I think let us know and we'll see what's the best way to configure something. Thanks.
Mm-hmm. Yeah, like a special interest group. Wonderful. Okay, guys, well, the sun is still shining, which is amazing. We've come to the end of the day, and we're very happy. Maria, you'll know, for you to know that the sun is shining in Ireland, which we're really, really enjoying. Sending you some sunshine, which is definitely unusual, as normally you'd be sending us sunshine. So wishing you all a lovely evening, and thank you for your participation and for this clinic. And we've learned, I know the team, all of us have learned a lot about, just about how what it means when we get together, the wisdom basically in the room, that it can be shared. So thank you all, and thank you, Zikar, I see you there, and to Catherine for your wonderful work and for your contribution to this discussion. So thank you, everybody. We will see you online very soon.
Thank you. Thank you.
Thanks,
Best of luck, everybody. Bye.
Bye. Bye. Bye.